طيب بسم الله الرحمن الرحيم. It's 8 o'clock. Uh, it's our pleasure and honor to present the webinar today. I would like to first thank the Saudi Society of Blood and Marrow Transplant for their educational activities for the career. And I would like also to thank Bristol Myers Squibb for their support of these educational activities. Tonight, we are going to discuss the very important topic with two eminent speakers, colleagues. So the topic for tonight is navigating the evolving landscape and optimizing early disease management. That's the myelodysplastic syndrome, a disease that's there, but it's always left over. So tonight we will hear from first Dr. Iman Al-Hazmi, who's a consultant of adult hematology and the head of hematology and oncology division at King Fahd Armed Forces Hospital in Jeddah, Saudi Arabia. Dr. Iman will put the disease landscape and a clinical unmet need. Dr. Iman, the floor is yours.
Alaikum. Good evening, everybody. Thank you, Dr. Bassem, for the introduction. Welcome, everybody. Because of time, I'll just go ahead and start with the presentation. The topic is too big, and I had to select a few points to discuss in 20 minutes. So as an intro, it was around 1900 when first time MDS was described, and till late 1980s it was given the title, but till nowadays we don't have really a international registries for MDS over the years, even though we could see the incidence been increasing from early on in the 1990 till 2021. That's the available data nowadays. And also there is a projected data for 2045 that the incidence will be increasing, maybe not the mortality, but will expect it to be increasing dramatically, especially with expected increasing in age. As we know that MDS is an age mainly happening in older age group above the age of 60, and the majority occurred above that age, like let's say 65 or 69, and the highest is the 85 with the mortality. And this is the international data so far, with the burden increasing in those older age group. However, the risk of MDS increase incidence, it increased from the age of 45. Even for low-risk MDS, of course, because it's a peculiar subtype of myelodysplastic syndrome, there are separate reports, and those data I'm discussing regarding the age group and the incidence is a sporadic literature been published from different geographical area, but there is no registries that describe myelodysplastic syndrome as a disease per se. So even for myelodysplastic syndrome low risk, the incidence, the median age is around 81. And of course, the most common presenting symptoms is symptomatic anemia. The ratio is around 50-50 for male and female. In general, myelodysplastic syndrome more common in male than female, but in low risk, it's around the same age group. Still, those data, as I said, been sporadically reported by different investigators, but all the international registries, they include myelodysplastic syndrome if they are including it really under the MDS MPN group or under leukemia registries. And with that, you don't really have specific data for myelodysplastic syndrome. And even if it's reported, like for GBD, they reported incidents in different countries for myelodysplastic syndrome, but there is no characterization of the subtypes of the myelodysplastic syndrome, the mortality, low risk, high risk, nothing reported in details about myelodysplastic syndrome. The same scenario for Saudi registry, because they align with the international data. Myelodysplastic syndrome is not reported as a separate entity. There is one report from Saudi Arabia, from King Faisal Specialist Hospital in Riyadh. They looked into patients who were referred with cytopenia, and they found that just above 50% of those cases were myelodysplastic syndrome. However, the median age is way younger than what been reported internationally. It's not like above the age of 65. I think we all agree on that. We see patients on a younger age group. Yes, we see old age as international reports, but we see younger age patients with myelodysplastic syndrome. And the male to female ratio is a little bit higher, is 1.6 male to female ratio. So we'll go, and that's the first challenge that we're facing with myelodysplastic syndrome, that we don't have really a good data and registry for myelodysplastic syndrome. The second issue is the diagnosis, because initially patients usually present with the vague symptoms, and their lab also is vague, and the diagnosis and subclassification of myelodysplastic syndrome is really complex, from the CBC to the bone marrow result to the cytogenetic and the nuclear molecular studies. Add to that for example, the bone marrow per se. You need, there are variation among the hematopathologists, and you want to integrate all, as we mentioned, the other diagnostic test, which is not readily available in all center. So this is one thing, the complexity of the diagnosis. The other is the later presentation. As I mentioned earlier, the symptoms usually is vague. Patient has fatigue, symptoms of anemia. They are usually older age group with comorbidity. So those manifestations, even if they have an anemia, it might be labeled as anemia of chronic disease, for example. Plus, there is a gap also in family medicine or primary care for patient with cytopenia, how to manage that and when to refer patient with such manifestation. I read the report about family medicine guideline recommendation in one of the countries, and they recommend to follow up the patient for at least 6 months prior deciding to refer the patient. And let's keep in mind that the patient most probably did not present as soon as they have a symptom. Actually, it took them a time till they decided to go to hospital, and still they are recommending to follow up the patient for 6 months at least before referral to a specialist. Add to that, some patients will not have an access for a hospital where there are hematologists, and this all add to the later presentation of myelodysplastic syndromes. So how can we help in that? Is there a way that we minimize this? Yes, maybe, especially nowadays in the era, of course, of AI. Artificial intelligence is everywhere. We've been talking about it in the last couple of years, and there are promising tests and trials for AI to help in diagnosis, starting from detecting dysplasia in the peripheral blood smear. And this is very promising, with a good sensitivity and specificity, with the area under the curve of 0.9, which is excellent for patients with myelodysplastic syndrome. Other potentials tests been also utilized for AI, whether to differentiate patient of aplastic anemia and myelodysplastic syndrome and ITB. With that model, they found that patient could be detected if they are aplastic anemia, and ITB more better than MDS. Still, it's better than the what we are facing nowadays. Also looking into the CBC only, that's another option. If the patient has an anemia or thrombocytopenia, there are different models looking into that. And for flow cytometry also, there are models that examine or help in improving detection and diagnosis of patient with myelodysplastic syndrome with a higher sensitivity and specificity with the utilization of a flow cytometry. Other models in AI has been tried to generate a risk factor to include multiple factors within the patient, including the IPSSR system to stratify the patients, and with that you make sure that the patient is fully evaluated, especially if we have the medical record, and including all the complexity of NGS results and other parameter. So and all an addition one of the method, for example, they are trying to look for molecular changes that can predict resistance for hypomethylating agent, another promising thing. So even if we are discussing the management of the patient, maybe we can in the coming future, are we going to get that or not? We're still not sure, but maybe we'll get an answer whether this patient a more tailored treatment. For example, we would know earlier when the patient is if the patient has MDS, and additionally we would know what is the best option of a treatment for the patient. Is hypomethylating agent is the answer or not? So how we could have a pathway for those different methods and models of AI and diagnosis of MDS. It could be utilizing early on which patient should be referred to hematology at the primary care, and then even at the hematology, which patient we need early to look for, try to do a bone marrow rather than observe for the patient, help in the bone marrow reporting and the flow cytometry results. At the end, as we mentioned, it can stratify the patient, give us a recommendation into plan on treatment, or which what would be the best option for patients. However, this is still in the trial stages. Most of the reports that you will find published is not externally validated. It's a single center. There are a few, the one that I've mentioned in this presentation, just one or two maybe have been data been used from multi-center, but most of them were single center results and data. You want to harmonize the data. The funding is an issue, how to implement it and make sure to minimize the mistakes and error of AI. And of course, the trust that we have in AI to really take the time. But I believe it's a good idea and a promising future, at least to shorten the gap that we have in the diagnosis. So that's for the diagnosis of patients, and then comes the patient needs, what really patient needs. One of the important factors in myelodysplastic syndrome is the quality of care, the quality of life, for patients with MDS. Myelodysplastic patients, the disease itself impact different domain, and you could say the whole life of a patient. From the physical domain, majority of patients complain of fatigue, dyspnea, generalized body pain, restricted mobility. And keep in mind, usually those patients have multiple comorbidities plus older age group. Even though they are 50s, we know how our patients in their 50s sometimes behave. Emotional demand domain also, patient more than 2/3 or almost 2/3 of the patients report anxiety, emotional stress, and fear of a progression, inability to work or carry their daily activity, and of course, whether of fatigue or other manifestation, they cannot travel, they cannot go around for holidays. Sometimes they are committed with a treatment schedule. and the dependency, having and needing a caregiver all the time, someone to accompany them all the time. The weakness and the fatigue does not allow them to be fully independent. Even though the fatigue is there, the fatigue is not related to anemia. It does not resolve by blood transfusion, by the way. And it's a major impairment and complaint for patients with myelodysplastic syndrome, impacting their quality of life. And a lot of patients report high fatigue score when they were assessed for that. Additionally, they have the pain, depression, and moderate level of anxiety when they are assessed for that. So when they look to quality of life for patients with myelodysplastic syndrome, whether they are low risk or high risk, and based on age and gender, you could see that majority of patients have impairment in physical function, social function. Of course, patient, as expected, patient with high risk, they will have more incidence of dyspnea, fatigue. However, even low-risk patient, you could see their functional, physical function and social function is impaired dramatically for patient with MDS. This is also for applicable regardless of the age and the risk group. So why fatigue persists beyond anemia, whether it is because of neuroinflammatory, the iron overload, oxidative stress, and the psychosocial stress of that. Additionally, this will lead to they discovered that IPSSR, when they included fatigue, and it's very important that we have the fatigue reported by the patient. And a lot of report looking into adding the fatigue and whether the cutoff is below 45 or above 45. And there is a huge difference in the prognosis of patients based on the fatigue score itself. So we need to look into fatigue, how the patient, they manage it. We might think anemia and transfusion would help, but you could see the patient usually trying other maneuver, trying to improve their fatigue, which are sometimes things that we don't think of. So we need to think again of quality of life fatigue for patient during clinical trial and the treatment that we offer them. Look into supportive care. Maybe we need to get more involved in geriatric assessment like a frailty test and cognition. We need to involve our colleague from geriatric assessment. I'm sure we look into iron overload and how to do iron chelation. One of the another important thing is the transfusion. Actually, we try to help patient by giving them transfusion, of course, because we cannot leave them anemic. However, anemia, transfusion also add to the comorbidity of the patient, and not because of iron overload by itself. We could see here, for example, the survival for patient, whether they're transfusion dependent or not transfusion dependent. In low-risk patient, we're not talking about high-risk patient. And you could see that the survival for patients who are transfusion dependent is almost like 50% less than patients who are non-transfusion dependent, with hazard ratio of almost 1.5. So the patient themselves, they are not feeling comfortable with the repeated blood transfusion, and they reported it negatively impact their life. Of course, having multiple units and frequent presentation to the hospital. In a few slides, we will discuss that impact of coming frequently to the hospital. And this is, again, it impairs the quality of the patient, and patient do not feel better for fatigue and dyspnea dramatically with the blood transfusion. For the hospital visits, there were reports about how this hospital visits and waiting time for patient, and they categorize patient into stressed patient and non-distressed patient. Regardless of that, patients were not happy, of course, about the waiting time, and they didn't like being coming to the hospital. Majority of patients need someone to accompany them, and of course that add to the burden. We will discuss that later, and I think we all agree on that. We see our MDS patients come for even for transfusion only. Usually they need the support. They cannot come by themselves to receive the treatment or blood transfusion, and it impaired the hospital visits, the frequency, impaired quality of life for patient in general, whether they are distressed or not. And almost 1/3 of the patients said waiting time was not acceptable, and the other 1/3 reported of it as a waste of a time. One of my family members usually said, if you have a hospital visit, forget about that day. You cannot do anything else other than that. And that's for a healthy person, not a person with for a blood transfusion, 4 hours at least, if not 5 or 6 hours in preparation. Majority prefer telemedicine. Nowadays, we have more and more telemedicine, but if the patient coming for a blood transfusion, that's an issue. But some of them really suggested and wanted to have like more than 1/3 of the patient would prefer to have a blood transfusion at home rather than coming in the hospital. This is a nice report. They looked into social media and what do the patients post regarding MDS. They took the videos of patients and then analyzed them, and they look what do the patient. Majority were reporting negatively, especially at the time of the diagnosis. They had concern regarding the diagnosis, and regarding the treatment option. Even watch and wait, it's very challenging, and I'm sure all of our patients who are watch and wait, they cannot accept the idea that they have a disease, still they cannot be treated. It is challenging and stressful for them, and the fear of progression and treatment failure. So a little bit there was a variation in what was the concern based on each country. So definitely the culture and the region will have an impact on how patients accept it and what do they expect. They had an issue with, they feel like there is no clarity about the diagnosis, the management plan. And this is posted from social media, so we could see that even our publication are getting updated and going into the same spirit of the generation of utilizing social media. So patients want an access for a new medication, faster treatment access, understanding the treatment option. It is a bit challenging for them. And the availability of treatment locally with an ease of diagnosis. And I think we, even us as a physician, we are aligned with their needs. We want that for them. One of the important thing for patient with myelodysplastic syndrome, chronic disease for in general, is the caregiver. Majority of the patients with myelodysplastic syndrome, they had a caregiver, and majority of the caregiver were a female. They reported the absence from work or changing their career, decreasing their working hours. Of course, sometimes work is not really supportive, so they stop working because of the time caring at home or bringing their loved ones to the hospital, taking from their time, so they cannot present and to the at work. They have their own stress impact their daily life, and this is whether, as we mentioned, in the hospital or and at home. So it is not even the patient, it's the whole family, especially in our culture here in Saudi Arabia. So anything else Yes, one more thing. We tend to forget as hematologists about palliative care. Our colleagues in palliative care in the hospital always say hematology is they don't refer the patient to us till it's nothing they can offer. They depleted everything. We kept a patient of MDS with us in the hospital for like 2 months, maybe almost approaching 3 months, 2 to 3 months, admitted under hematology. And after referring him to palliative care, within 3 weeks, they managed to discharge him, and he spent a good time at home. He had 2 3 weeks been requesting us to discharge him. We hematology, we cannot do that. We could not do that, but they did manage. So we need to think more of palliative care early referral for hematology. I'm glad it is not just the hospital, us in the hospital or hematology in Saudi Arabia. Internationally, hematologists had a late referral to palliative care until they don't refer till the last resort. They tried everything. But palliative care can really be supportive and helpful and give a holistic support for the patient. We should not think about it as end of life. And that's, I believe, that what we are doing, to be honest, as a hematologist. What we could do, we could refer as early as possible when the patient is a high risk, and we try to evaluate the patient frequently, just in case the patient change their risk, and involve them as a team. And they usually palliative care, they have the social worker, they have the psychologist, they know how to manage patient symptoms. They have religious affair member who could support them, in that too. And to discuss end of life care, they are the best people to manage to discuss that issue. We want to treat the patient. They know how they want to comfort the patient and their caregiver. Even the caregiver, usually they have the management plan for the patient and the caregiver. We don't have that, unfortunately, not as them. So in conclusion, I believe that we need to take in consideration the registries and the number of myelodysplastic syndrome in details, the risk of the patient, the survival, the option of treatment. We need to look into how to shorten the duration of the later presentation. AI, when it's going to be helpful, we don't know yet, but I think hopefully soon. But we need to think now how to shorten this within the hospital, and how to have a pathway between family medicine and the hematologist to shorten the waiting time for referral. So we and I think this is the last two slides. As I mentioned, we always want this. We want the best option of treatment. We want a curative option of a treatment for patients, but we need to think of other issues the patients suffer from: the fatigue, the dyspnea, the other things that impair their quality of life. We need to improve the patient experience in the hospital and how to make it more successful and shorter stay from the time they come into the time they leave, and to integrate quality of life in our trial, in assessment of our own patient daily to daily day by day, and to include palliative care to ensure the patient receive holistic approach. And this is, I believe, what matters the most. We need to look into the patient as a whole. And we cannot do this by ourselves. We have to have support from other team member. It's a multidisciplinary team. We need to rethink patient journey in the hospital and how to improve that, and how to support you from all aspects. And with that, I will conclude my presentation. Thank you very much.
Thank you very much, Dr. Iman, for this excellent presentation addressing the disease, the challenges. So, without delay, we will go to our next speaker, Dr. Badr Al Ahmari. Dr. Badr is consultant of stem cell transplant and cellular therapy division at in the Department of Oncology at King Abdulaziz Medical City at Ministry of National Guard in Riyadh. And also, Dr. Badr is the chairman of the Blood and Cancer Research at King Abdullah International Medical Research Center in Ministry of National Guard. Dr. Badr will address the earlier is better, that's a wisdom words, optimizing the management of MDS. Dr. Badr, the floor is yours.
All right, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah.
Assalamu alaikum wa barakatuh.
Thank you, Dr. Bassem, for the introduction, and thank you, Dr. Iman, for the excellent overview showing the disease burden, the significant burden of the myelodysplastic syndrome. So I'm going to talk about the management approach of low-risk MDS. If we look historically, we know that erythroid stimulating agent is the first line treatment for low risk MDS. And the aim of this agent is to improve the transfusion independency. Looking into a large data set of more than 1,600 patients, we know from this data that around 40% of patients will have a primary failure for this kind of treatment, and then around the 1/3 of patients they will respond initially and they will fail immediately. And there are longer responders, around 30% they will respond, but they will lose their response in 18 to 24 months. There is also an interesting randomized study where they randomize patients who are transfusion independent into using ASA versus placebo, and showing there was an improvement in transfusion-free period for those patients who initiated the erythroid stimulating agent even before the need for transfusion to maintain hemoglobin around 10. So based on this, there is a gap and there is a need, an unmet need in the treatment of low-risk MDS. So luspatercept is a first-in-class erythroid maturation agent, which is a recombinant fusion protein, consists of a modified form of extracellular domain of the human actin receptor 2B that is linked to a human immunoglobulin FC domain. This will actually bind to a TGF beta ligand, and this kind of binding will inhibit the actin activation. That will lead to decrease in the SMAD phosphorylation, and that will lead to enhancement in erythroid maturation in the late stage erythropoiesis through the enhancement of the proliferation and maturation of the erythroid precursors. So this is basically what is luspatercept. It's a subcutaneous injection. It has been approved for treatment of low-risk MDS. So MIDAS trial is the first randomized study that tested this agent in those who fail erythroid stimulating agent, or those who are naive to erythroid stimulating agent but have a high baseline erythropoietin level, randomized between luspatercept versus placebo. With the primary endpoint was met in this trial, which is more than 8 weeks of transfusion independent, around 38% in the luspatercept arm versus 13 weeks in the 13% in the placebo arm. So the question, why not to move this into the upfront setting for low-risk MDS? And this is the design of the COMMAND trial, which is a phase 3 open-label randomized control trial enrolling adult patients with low-risk MDS, which is basically our IPSS are low, very low, low, and intermediate, with a diagnosis of MDS with or without ring sideroblast, with a less than 5% of blast, who are transfusion dependent, and also they are erythroid stimulating agent naive population. Patients were stratified based on their transfusion burden, erythropoietin level, or RS or ring sideroblast status, whether negative or positive. They were randomized into luspatercept versus ibutine alpha, and there's the specific schedule of dosing and titration of both agent. With the primary endpoint was actually the achieving RBC transfusion independency for more than 12 weeks, plus an increase in the hemoglobin level of at least 1.5 gram per deciliter. Looking to patient population, median age was 74, with a time from diagnosis of the MDS to the enrollment in the study was 8 months in the luspatercept arm, 5 months in the erythropoietin stimulating agent arm. Looking into the transfusion burden, more than 4 units per 8 weeks was seen in around 40% of patients in both arms, and hemoglobin less than 8 was seen in more than 60% of patients in both patient arms, indicating a huge disease burden. Around 60% in each arm having the SF3B1 mutation, and ring sideroblast positivity was around 70% in patients. The primary endpoint was achieved with the 60% of patients in the luspatercept arm achieved the primary endpoint versus 35% in the ibutine alpha arm. And this primary endpoint was seen in different subgroup population, was seen in those with low and high transfusion burden, those with low and high erythropoietin level, and those with or without SF3B1 mutation. In the ring sideroblast patient, it was the response was prominent in the patient with ring sideroblast positive patient. However, it was equivalent in the ring sideroblast negative population. Looking into duration of response was actually significant and in favor of luspatercept, with a median of 129 weeks for luspatercept arm versus 89 weeks for erythropoietin arm. In terms of safety, there was no major safety signal seen in this study. There are an increase in diarrhea and fatigue in the patient with taking luspatercept, as well as hypertension. There was no difference in terms of high risk progression to high risk MDS or progression to AML. 4% were seen in both arms. And looking into an RBC transfusion-free period was actually longer for the luspatercept, with a 155 days versus 42 days in the ibutine alpha arm. There was actually improvement in the baseline hemoglobin level, which was higher in the luspatercept arm. And if we look into longer data or long-term data with more than 2.5 years of follow-up, the sustain of response and cumulative duration of achieving the primary outcome, which is transfusion dependent more than 12 weeks, was actually sustained in the luspatercept arm versus erythropoietin stimulating agent arm. And these responses was equivalent across the whether the patient are having high transfusion burden or low transfusion burden. It was more prominent in those with ring sideroblast, the cumulative duration of achieving the primary endpoint. However, in the ring sideroblast negative, despite it wasn't really statistically significant, but these responses looks better when it's compared to erythropoietin alpha. Again, the duration of response was more prominent in the patient population with low erythropoietin level, less than 200, versus those who have more than 200 baseline erythropoietin level. And what was really interesting after long-term follow-up, there was actually an improvement or trend toward improvement in overall survival for those who receive luspatercept, with a 20% reduction in the risk of death associated with the use of luspatercept. And if you take those who survive 3 years from randomization and then they compare both population, there was actually significant improvement in the overall survival in favor of luspatercept arm. Looking into the patient-reported outcome and quality of life questionnaires, which is an important tool to assess patient own perception of quality of health and others, as mentioned by Dr. Iman. This this actually was significant in favor of luspatercept across different domain, which was tested during this randomized study in a prospective way. There are other agents approved for low-risk MDS. We're talking about imetelstat, which is a telomerase inhibitor, based on the data from EMERGE study, which is a randomized phase 3 study, enrolled patients with low-risk MDS who are refractory to erythroid-stimulating agent or failed erythroid-stimulating agent, or are naive to erythroid-stimulating agent with a high erythropoietin level of more than 500, and they were transfusion dependent. They were randomized into imetelstat versus placebo. Imetelstat is an agent that is given intravenously and given every 4 weeks. And the primary endpoint was an 8 weeks of transfusion dependency. Looking to baseline characteristics, median age was around 72, 73. Median time from diagnosis was around 3.5 years versus 2.8 years. 60% of patients, they were RS positive. And looking into the median baseline hemoglobin was equivalent between both arms, 7.9 versus 7.8. And looking to transfusion burden, around 40% of patients or more, they are requiring more transfusion with more than 6 units per over a period of 8 weeks. And the median erythropoietin or EPO level erythropoietin serum erythropoietin level was actually a little bit higher in the placebo group versus the imetelstat group. The primary endpoint was met in this study with around 40% of patients. They achieved the primary endpoint 8 weeks free of transfusion versus 15% in the placebo arm. And looking into safety profile, imetelstat, it can induce around a grade 3 to 4 adverse event in form of thrombocytopenia can reach up to 60%, and neutropenia can reach up to 68% in the imetelstat group versus only 8% in the placebo arm, and for thrombocytopenia, and 7% for anemia. So that's a significant safety profile for this specific agent. And there was actually reported febrile neutropenia of grade 3 in at least one patient during the trial. Another interesting study that I would like to present here, looking into the 5Q, low-risk 5Q population, that we know that lenalidomide is a standard of care for those patients based on at least one randomized study that showed improvement in even overall survival for those patients, decreased risk of death and AML transformation. But what is interesting here, this is a Spanish study that where they randomized patients who are not transfusion dependent with the 5Q MDS with a hemoglobin of less than 12, but they are not transfusion dependent. And they randomized them between 5 milligram of lenalidomide versus placebo. And the primary endpoint was the time to transfusion dependency. And you can see here the curve after more than 5 years of follow-up, of median follow-up, the median time to transfusion dependency was not reached in the intervention arm or lenalidomide arm versus 11 months in the placebo arm, indicating the powerful effect of even small dose of lenalidomide to make this patient maintain their transfusion independency over many years. Another option for those who fail the initial options that we mentioned in the previous slide, we can use hypomethylating agent for a subgroup of patients. There is no well-designed randomized study for those patients. However, there are some data support shorter course of azacitidine of 3 days. Azacitidine showing better response when you compare it to azacitidine, and can achieve the transfusion independency up to 30 to 50% of those patients, indicating a possible option for those patients. Also, we can utilize the oral azacitidine for those patient population, and they can achieve transfusion dependency up to 30% of patients. So, I mean, now in the low risk MDS, we have multiple agents, as we discussed, that can be considered an option for those patient population, which make their treatment algorithm become more and more complex, which is something good to have some complexity, indicating that patient can have options for treatment based on their baseline profile, disease burden, genetic mutation, whether they have STF3B1 mutation or not, whether they have 5q deletion or not. So these multiple options, we can tailor the treatment up to patient baseline characteristic. And we can move from one option into another once they fail. I mean, there are some retrospective data showing that patients who receive luspatercept in upfront setting and they fail luspatercept later on, they still can have some good responses with erythropoietin stimulating agent. So we can sometimes move from one option to another. One option for those with 5q del negative, ring sideroblast negative with high erythropoietin, baseline erythropoietin, probably we don't have to go into luspatercept, but maybe imetelstat consider an option for those patients, but we have to be careful in terms of cytopenia that can be seen with this agent. I think I've reached the end of my presentation, and thank you for your attention, and happy to take any questions.
Thank you very much, Dr. Badr, for this excellent presentation, very detailed, and it really showed the promising drug that we are having in patient care. I'm trying to see if there is any questions or I don't know from your screen, can you see any questions, Dr. Badr or Dr. Iman?
I think there is a question for Dr. Badr. Is imetelstat used in the KSA? In KSA, is it used in Saudi Arabia?
Well, it is not registered yet in Saudi Arabia. I haven't used it myself. Yeah, so I have no experience using this agent.
But luspatercept is registered in Saudi Arabia, and it is, I don't know if it is formulary in all institutions or not, but it is available in Saudi Arabia, and it is really a good drug. I do have one patient with MDS who was suffering, as Dr. Iman mentioned, with the anemia. I mean, we did use the APO and the other And the luspatercept helped the patient from the hemoglobin 6 to 7 to 10 to 11 with and that's very, very promising effect that I'm seeing in this patient. And as Dr. Iman mentioned, the quality, and in the presentation you mentioned, Dr. Badr, the quality of life, everything changed with luspatercept.
Correct. Yeah, I totally agree with you. I mean, any intervention that mitigate or reduce the risk, the transfusion burden is a huge gain for those patients. And Dr. Iman nicely illustrated in the slide that she presented how to what degree the patient's suffering. I mean, coming to take the transfusion, even if it's one transfusion every, let's say, 8 weeks or so, that's a lot for them waiting and coming the next day to get their blood transfusion and toxicity from the blood transfusion. And Dr. Um, Bassem is, as you are the advocate for
No
thyroid blood
transfusion,
transfusion.
yes.
Yeah,
Yeah.
so that's really an important gain for the patient. It's not the issue of looking into overall survival benefit or whatever. No, we're looking into other levels to assess the value of this intervention for our patient.
Dr. Ayman, can you see from your screen? Because I don't have the...
There is a question regarding, thank you for your comprehensive talk. Kindly comment and share your experience with the use of low-dose chemotherapy for palliative care in case of MDS, whether there is a progression to AML or not. I think like slow progression of patient with MDS with chemotherapy, maybe low dose RSC, they mean, because it's written low dose chemotherapy.
Yeah,
What is your
probably. Yeah.
experience with that?
Yeah, I mean, we're talking about high risk MDS, and we are talking about now completely different way of approaching patients with high risk MDS. I mean, those patients should have go to transplant if they are fit for transplant, and if not, then I mean, there are agents that is already approved for this, such as hypomethylating agent for those patients. More recently, sometimes incorporating venetoclax for such patient population, although it's not approved yet for high risk MDS. Yeah.
Yes, I agree. I think azacitidine is a good drug, and I have another patient who has MDS now for 9 years on azacitidine. Initially was monthly, but now every 2 months. I offered him transplant, but he turned down the option. Now he is reaching 76 years old, and he's doing well. He had initial anemia, did receive transfusion, but with the azacitidine, he had stable disease for years now. And I will continue with till disease progression, but till now he's stable. And also he saw Dr. Ghulam Mufti. He went to UK and he met Dr. Ghulam Mufti. So these two patients can really explore from low risk to intermediate and high risk. And transplant is also an option that if available and the patient agreed, that's another issue. It will be another ultimate. Any other questions?
I really don't see any questions, right, Dr.
I don't see any question.
Yeah,
and I cannot access the Q&A. Okay,
yeah.
now actually there is
In the
under
chat.
Q&A. Actually, there is under Q&A.
There is
question.
under Q&A. Where is it?
If you go to more, you'll find it. Yes, it wasn't appearing to me.
Mm-hmm. I
think we discussed already the role of PMT, and as you mentioned, Dr. Badr, stem cell transplant usually for patients with high risk who are fit for transplant. Because there is a question, any role for BMT and MDS?
Yeah. And the question maybe for you, Dr. Iman. They said, do you foresee any future role in advancing imaging or AI-based role in improving the early detection and monitoring of MDS patients? So probably this fits nicely into the presentation that you just highlighted.
Actually, there are multiple different reports from different countries and different regions of the world discussing how AI can help. The initial report, like one of the one I presented, they externally validated. So they had the three data from three different centers, and they used two data, and one was the external validation. However, the different reports from around the world, they are really promising for even detecting early cases. So now they are comparing it with what we have as a diagnosis, but it is really promising. I hope we could see it soon to shorten the duration from the presentation. I'm sure we all agree that we see patients at least 6 months been suffering from fatigue or symptomatic anemia, especially if they are living in outside cities, not like in the main cities, Jeddah, Riyadh, Medina, where big hospital and hematologists are around. So I hope AI will be helpful in picking up the cases that we miss.
Yeah, absolutely. I totally agree with you. And even for the current existed scoring tools, such as the IPSS R and M. I mean, there are some ways to improve this and incorporate this into an AI models to select the best patient that can benefit from early intervention from these agents we just mentioned, the ESA and luspatercept. During the last EHA, they were talking about incorporating erythropoietin level into these models. Just only erythropoietin level can actually highly predict patient who will really benefit from ESA in the upfront setting. So still there is room for improvement, yeah.
Yes, so ideally, it should help us to shorten the duration, get more accuracy in the diagnosis, and tailor the treatment really well for each patient. Because the data is complex for patient with myelodysplastic syndrome. So from the time of picking up the cases till the end, when we tailor the treatment based on each case scenario, I think it will help pretty much, hopefully.
Okay, there is another question to Dr. Iman. What are the red flags that should prompt clinicians to suspect MDS and refer patient early? Yeah.
Of course, cytopenia. And sometimes I always teach the residents, if I'm in the round, do not tell me the MCV is 90 and this is normocytic anemia. I know that the parameter said 80 to 100, but whenever I have low threshold, maybe because I see a delay in management of patient of MDS and diagnosis, whenever the MCV is 90 and above, usually there is a slight of anemia or thrombocytopenia, leukopenia. If there is no vitamin B12 deficiency, there is no CLD disease, of course, we're excluding peripheral causes. But if there is a high MCV, even with a single lineage thrombocytopenia, for example, I would go ahead and do bone marrow. And I do my best to convince the patient to go ahead and do bone marrow.
Great. I don't see any other questions in the Q&A and chat. No other question. So
the risk of thrombosis, I think. There is a question about risk of thrombosis with luspatercept, Dr. Badr.
Yeah, that's a new question.
Yeah, I mean, yeah, this is an interesting question. And this is important because risk of thrombosis was not significantly higher or noticed to be a major issue in the MDS cohort. Probably this was seen in the thalassemia cohort patient population, but this was not really a safety signal that was recognized during the conduct of both trials. Yeah.
Okay.
I think that's it. Let's see. I don't think there is any question. It's already 9.
Okay. Thank you very much, Dr. Iman. Thank you very much, Dr. Bedr. And thank you, Southside of BMT. And thank you, Bristol Myers Squibb. And thank to all attendants who attended this educational activity. And we'll see you next week with another SSBMT activity. Thank you all.
Thank you.
Thank you very much. Good night.
Good night,
everyone.
Maisa.
Nice.